Well, good afternoon. I am not a poet, so that's a hard thing to follow. But thank you, Jim, for that warm welcome and for your support and willingness to host. And thank you to Jennifer and Jill, who I guess have been renamed, what was it? Master of the Universe or something? Mastermind. Masterminds of the conference. And I also wanted to give a quick shout out to our ACL staff who are here, Greg Link and Kevin Foley, who are your support at the federal level for all much of the great work that you do. So first of all, I love the notion of your conference theme, right? This idea of creating harmony for families who have caregiving responsibilities. And I echo Jim's comments. I heard that you wrote a great song about it this morning, and we'll all be watching for that in the top 10. Or maybe not. At the Administration for Community Living, as we're thinking about issues related to respite and caregiving, we're seeing a lot of value in thinking about this broadly and really trying to figure out how do we advance the goal of ensuring that both the person at the center of services, right? So the older adult, the person with a disability, we have lots of different language that we like to use in different spaces, right? The consumer, the beneficiary, the care recipient, and the family members who are providing support are able to both maintain a quality of life that is not compromised in terms of health and well-being, and finding that balance. And that's what I know you guys are doing every day in your work with families and caregivers. So a little bit about us. Some of you may know some of this and some of you may not. But the Administration for Community Living is the newest entity within the Department of Health and Human Services at the federal level. We established the agency in April of 2012. The Secretary and the President supported and endorsed this notion that community living is a fundamental aspect of what we need to be thinking about when we're talking about people who have functional support needs, right? So older adults and people with disabilities. And for too long and far too often, we are siloed in our approaches. And we have not been able to garner an adequate level of attention around these issues. And so the Secretary said we need to make sure that this is something that is a focus of the department. And in doing so, we brought together the Administration on Aging, the Administration on Developmental Disabilities, and at the time, the Office on Disability. As of a couple months ago, thanks to Congress, the Workforce Investment and Opportunity Act is now bringing over the independent living programs, so independent living centers and silks and that whole line of federal funding, as well as assistive technology programs, and the National Institute on Disability, Independent Living and Rehabilitation Research. Some of you may be familiar with it as NIDR. We're now deciding that we need to call it the Institute because NIDLR, under its new name, sounds like cough syrup. But that is an incredible gem in the federal government that is focused on research and policy implementation related to people with disabilities, across the lifespan. And so those programs are coming into ACL, which makes the ACL has been part of ACL's growth, and allows us to say that in the time that since we created ACL, we've gone from what was AOA at about 100 staff, and I think, Greg, you can probably correct me if I'm wrong on this, about $1.4 billion in funding to, when this transition is over, someplace in the range of 225 or so staff, and upwards of $1.8, $1.9 billion in programs. So we're bringing these pieces together on a relative scale for HHS. That's all really, really still very small, right? We're still the David to the funding agencies that are the Goliath that is CMS. But what is important in that is that it is creating an opportunity for program and policy development that really focuses on this fundamental right that we have established as our mission, which is to maximize the independence, well-being, and health of older adults, people with disabilities, and their families and caregivers, and a place in the federal government to really build upon, the authorized programs that come to us through the Older Americans Act, the Developmental Disabilities Act, and now the Rehabilitation Act, as well as some of the public health service programs that we have, and really move towards this vision where everyone feels like they have the opportunity to be supported to live across the lifespan in community. We know that for many people with disabilities and older adults, access to home and community supports are the critical factor and the determining basis in ensuring whether they can exercise that fundamental right to live where and how they choose. We also know that those services relate to more than healthcare and health-related services. The availability of appropriate supports affect opportunities in housing, employment, education, childcare, social participation, for that population holistically. Across the country, advocacy efforts of the aging and disability communities have been aligning with this common vision and shared perspective developed from that foundational value. And in saying that, it's important, and I'm going to say some things today that are going to feel like sometimes this applies to disability and sometimes this applies to aging. And it's important that we've worked really, really hard within ACL and with all of our stakeholders to acknowledge that there's this shared vision that is foundational to the work that we're doing, but simultaneous to that, we have to acknowledge the specific and unique needs of each of the subpopulations that we're working with, and we don't think that there is one size that fits all. So we know that a senior with dementia versus a person with a physical disability versus a child with an intellectual disability will all experience different challenges in our communities, and their families and caregivers are going to experience different challenges in our communities, and we'll continue to maintain specific initiatives and programs that meet those unique needs. But again, there's a lot of opportunity in the space that is shared around this notion of what does it take? How do we support people at home? So Lifespan Respite is a program that from its inception and the earliest development was really intended to serve families supporting both older adults and families supporting people with primarily intellectual and developmental disabilities. I'm actually, more recently than having grown up in Michigan, consider myself an Oregonian. I lived there for nearly 20 years. And I know that when in our state, we were one of the states, along with Tennessee, that were the first implementers of Lifespan Respite as a concept, and the funding actually came from the Developmental Disabilities Council in Oregon to begin to think about the program. So we've seen it come in from both sides, and certainly the AOA caregiver program has been a critical resource in developing respite across the country. So this idea of these intersections are not new, right? I mean, we've been having these conversations in bits and pieces across the country for a long time, but the pressure and the opportunities to address the issues of family caregivers as the population ages, as the demand for long-term services and supports increases, and as more people are seeking health-related supports and are having to rely on families as the backbone of that support. We have to begin to push this conversation harder from more corners. And we need to understand the needs and preferences of the families and the people that they are supporting in order to capitalize on both the opportunities that I think are going to occur as a result of some systems change, as well as the growing demand. All that being said, at the end of the day, this is about families, right? So Jim mentioned that I am a parent, and I have an almost, it's hard to say this, 18-year-old daughter with an intellectual disability. And we've had our fair share of challenges, you know, along the way, having lived in a couple of different states. But as I think about what families need, I think we have to think about the role of community. And for our family, that's played out in a lot of different ways. When my daughters were little, I was a single mom, and I had a 3- and 4-year-old at home, and we were living in Oregon. And despite our fabulous efforts at trying to stand up and address respite needs and family support needs and waiver issues, the resources that are available to most families in that state at that time for family support were slim to none, and there were none available to us as a family. I often struggled to find time to do the day-to-day tasks, right, that a lot of other people take for granted. You know, how do you get to the grocery store, right? How do you run the errands? Sometimes, how do you go to the bathroom with the door closed? Formal respite care, access to quality child care, formal paid support services were not something that were available to me, and so I had to figure it out, right? So this is what families do. Families think about it. Families do the best that they can. And we managed to meet our needs. I was very, very fortunate because we were able to meet our needs on the day-to-day efforts of friends and a supportive community, and some really, really great college students, you know, who are now still part of my daughter's life 15 years later. But one of the things that we did is we discovered this little grocery store in our neighborhood, and at the time they were relatively new. Now they're ubiquitous, Trader Joe's, right? So if any of you have been in a Trader Joe's, the difference between Trader Joe's and a lot of grocery stores is relatively small, right? I mean, they're not your big, super giant grocery stores. I don't know what the grocery stores are here in Nashville, but you know, the Giants or the Safeways or the Krogers, wherever you're from in the country. Trader Joe's is relatively small. So I would take my girls and we would go shopping, and it was a pretty consistent staff who were there every time we showed up. So they started to get to know us. We went kind of at the same time every week so that, you know, the same people were there. And then my 4-year-old daughter with an intellectual disability figured out that they had balloons. This is a key part of going to the Trader Joe's. So we'd get to the Trader Joe's and we would tie a balloon around her wrist and put on a really long string. And I'd let her go in the store. Okay? All the staff knew us. I could see where she was by the balloon bobbing up and down in the aisles. And I got an hour. You know, I got an hour of like putting groceries in my cart without a 4-year-old either grabbing other things and putting them in my cart, or, you know, all the other things that can kind of go along with grocery shopping. She got some freedom. I got a little bit of time. We did that for a long time, and then when we moved from Oregon to the DC area, one of the first things I did was like, okay, I gotta go find the Trader Joe's. And, mind you, at this point, she's in 4th grade. So, she's then 10. But, this had become a routine and part of our life, right? So we find the Trader Joe's, and we start making friends with the new Trader Joe's in our neighborhood. And then when she was in middle school, she was involved with an after-school activity called Odyssey of the Mind. Some of you who are family members may know what that is. It's a great opportunity for kids with disabilities because it's about multiple intelligences and how do you get everybody to contribute. So their team had come up with a project that involved balloons. So Zoe was then able to be the contributor who knew who to call to get the balloons, right? So we built a little script, and she made the phone call, and she called the manager at the Trader Joe's and was able to manage the process, set up the pickup, get the right number of balloons in the right color, nothing like middle school girls for a set of particulars that have to be achieved. And she was able to do that and get the balloons and be a full contributor and be a member of a group of kids who then did pretty well in their Odyssey of the Mind thing. It's an unusual place to develop social capital and relationships. And I'm not saying that visits to the grocery store are in any way a replacement for formal services and supports. But I think it's important that we understand the role of community, the role of social capital, and the opportunity for isolated people to look beyond formal services and supports for how they meet their needs. And that's not a conversation we have very often. For our family, it meant that there was then a group of people that would get her a set of balloons, but also we saw at the local taste of our town, right? The little food festival that lots of communities do. And they were there and they'd ask her about school, and from that, it built a group of people who were invested in her life beyond me and beyond our friends. We don't do that with families. Families have a lot of caregiving responsibilities, whether it's, again, older adults and our aging parents or, spouses or siblings. At the same time as they're dealing with pressures related to younger members of families, balancing all of this. And we have to figure out both. We have to figure out how are we going to bring formal services and supports into people, and how are we going to ensure that they have social capital and are connected to the community in a way that often degrades as people become isolated because of caregiving responsibilities. How do we make sure that people have peer-to-peer relationships and the opportunity to meet their social-emotional needs in natural ways, as well as meeting their caregiving demands? As we continue to think about public policy in the area of supporting family caregivers, resources are shrinking, right? We all know that. I heard the pitch about all the money we need to spend in the state of Tennessee to up the revenue for the state. But every state is in that bucket, right? The new normal that states have been living in over the course of the last decade is challenging our systems. We have an increasing, I have to tell you guys, an increasing number of people who are aging, who have family caregivers in these circumstances. We have, a situation where we have created a reliance on Medicaid as the primary payer of long-term services and supports in this country at the same time as state budgets are stretched. And we have, a political debate that's ensuing in this country around, the role of government, taxes, revenues, and how is all of this going to look in our public systems going forward. So how are local communities going to respond? How do we develop and support statewide systems that encourage collaboration and coordination and are not just pockets of local activity? How do we move the systems change? How do we define this need and help people see that a little bit of support at home can save us a lot of resource and a lot of heartache on the other end for people who end up in provider-controlled settings that could have been avoided when their preference would have been to be at home? How do we ensure that families who have a very high level of resource need have their needs met at the same time that families who, with just a little bit of help, can stay whole? And how do we address that fluctuation? You know, what I need on my plan this week may not be what I need on my plan next week. And how do we do that in a way that builds trust? And one of the conversations I was in recently around family support issues related to kids was, you know, around what have we done in terms of creating a culture where families feel like if they don't max out what's available to them at the point that it's available to them, it's not going to be there when they need it. And we will never get out of the scarcity of resource conversation that we're in if we can't address some of those dynamics. So we have a lot of conversations, a lot of policy work that needs to be done to move this forward to ensure that family caregivers are well supported in this country. So we have some pretty sobering numbers. I'm sure you guys are familiar with a lot of the data, but you know, depending on whose estimate you want to use, we have somewhere north of 45 million people who are supporting another adult family member with functional limitations. I use those words carefully because we have such interesting data, right? Are we talking about people with disabilities? Are we talking about people with chronic health conditions? Are we talking about older adults? But in general, we have tens of millions of people in the country who are providing that care and supporting somebody who has a limitation in daily activities. The average family caregiver for an adult is a woman, is 49 years old. Look around the room. And often has the responsibility of providing that care and working outside the home. Our demographic has fundamentally shifted. You know, most families in this country are struggling to make it economically if they only have one income, right? We have a lot of families who, by virtue of the need to survive, don't have a stay-at-home family member in the house anymore. AARP estimates that the uncompensated caregiving that goes on in this country is worth $450 billion. Right? That's a lot of support that families are offering to people. You know, by way of comparison, Medicaid spending on long-term service and supports in the same period amounted to about $119 billion. Families are the #1 long-term service and support in this country. 2 out of 3 older people who receive LTSS at home get all of their care exclusively from family caregivers, and only about 9% are able to then have paid providers outside of the family. 75% of families caring for children with intellectual and developmental disabilities report that they cannot find after-school care, non-institutional community services, trained and reliable home care providers, summer care, respite, residential care services at all. Right now, we have nearly 11 million people who need long-term service and supports in this country. It's anticipated to double by 2050. The formal system of paid services and supports is ill-prepared to accept, manage, support navigate those numbers. On an individual level, we know the fiscal impact on families can be devastating. 27% of caregivers report a moderate to high degree of financial hardship as a result of caring for a loved one. I think that's a conservative estimate. Among families caring for kids with IDDD, 21% report spending over $1,000 a month out of pocket for supports that their child needs. Caregivers of people over age 50, we have some pretty old data, but the old NAC survey says, the average is $5,500 a year for older adults. The income-related loss to family caregivers age 50 and over who leave the workforce to care for a person with disabilities or functional support needs averages close to $116,000 over the course of their working lifetime. Not to mention another $200,000 in lost lifetime Social Security and pension benefits. The economic impact reaches into our private marketplaces. American companies experience an estimated cost of $33.6 billion a year in lost productivity, in addition to paying an estimated $13.4 billion a year in higher health costs due to the physical toll taken on people who are caregivers who are trying to balance work. So it's a tough set of numbers. The work that you guys are doing is critically important, and I would argue undervalued. Federal policy at this point at the Department of Health and Human Services, obviously a lot of the activity and the conversation is around the Affordable Care Act. The Affordable Care Act creates opportunity, in particular for younger populations, in improving access and affordability of health care, and provided states some important tools in terms of their Medicaid-funded long-term service and support systems to rebalance in favor of the community. For the first time since the first Katie Beckett waiver back in 1981, 82, we are now at a point in our Medicaid expenditures where we are tipping over to more money being spent in the community than in institutional settings. We're right at that 50%, just over the line. And, and we have great variability in that, right? So you've got states like Oregon that are out on the leading edge that have 78% of their money in the community. And then we have some of our friends who shall remain nameless who are still lurking in the 27 to 29% of their resources in the community. It's not consistent with people's preferences. It's not consistent with people's needs. And frankly, it's not cost effective. We know that nursing facility care and institutional care is the most expensive mechanism for supporting people, and we know that people with very, very complex needs can be well supported if the service and supports can come home to them using person-centered tools and acknowledging the balance of medical, social, health supports for both the individual and the caregiver. So in that, each of you from a different state has a different opportunity in engaging around what does that mean in your state. How, is your state looking at options like the Community First Choice option, which brings personal attendant services into the state plan for the Medicaid population, the Balancing Incentives program to, again, move the systems towards home and community-based relative to institutional settings, and as well as new options under dual demonstrations and 1115s, and again, pushing towards community. The under 1915C, and I know some of you deal in Medicaid and some of you don't, but Medicaid has become our primary payer. And this year, we put out a really important rule from the department that fundamentally defines what we mean when we talk about home and community-based services. Since the beginning of home and community-based services, they have been defined against what they are not. They have been defined as they are not institutions, they are not nursing facilities. But states have been left to their own devices to determine what they are. As a result of that, we've seen some really, really creative things and some really, really not so creative things. I guess a good way to put that. We have entities across the country, and I don't think there's a single state that can say that they're 100% certain that not a penny of their home and community-based services are going into environments that are institutional in nature, right? Provider-controlled settings that are restrictive in terms of choice and opportunity, are not driven by the person or their family, and are creating barriers to the broader opportunity to live at home or in the community. So the rule was published earlier this year that begins to define that for states, and states are now in the process of developing an analysis of where they are and are not in compliance with that regulation, as well as what they're going to do to move forward on improving their systems. And this is a statewide process. This is aging and disability, soup to nuts, on all Medicaid waivers. If you are not engaged in that process, you need to be paying attention, because this is going to drive where the system goes over the next decade, and is an important shift in focusing on the values and focusing on what's important to people who are receiving services, and acknowledging that right to choice and integration. We also have a changing landscape in terms of person-centeredness writ large. This rule, for the first time, really lays out on a regulatory basis what we mean when we say person-centered planning. Some of you may be doing person-centered planning. Some of you may be really familiar with person-centered planning. Some of you may still be thinking about what we used to call options counseling, right? Person-centered planning is fundamentally different. It is not options counseling. It is not sitting down and saying, this is a list of the public services that are available to you. Check off what you'd like. It is a way of thinking that is driven by the person, the support team that they've put around themselves, including the family, friends, formal and informal supports, to drive towards what's important to them, not just what's important for them. And that's important. That's a difference, right? So what is important for my daughter is that we're making sure that the elements of her health needs related to medication and elements that keep her healthy are supported. What's important for her right now as a senior in high school is that she has the opportunity to go to the homecoming game, right? And those are equally important. They're both important. And for too long, when we've thought about supporting people, we've thought about health. We don't think about health should be a means to an end, right? Health, the services and supports that we're providing in the family home should be about meeting the goals that they're interested in. And that is also a fundamental change in that we now have regulatory language, and we also, in January, out of the Administration for Community Living, issued a document that at the time Secretary Sebelius distributed that talks about the need to move home and community-based services writ large, not just Medicaid-funded services, but all services towards this notion of person-centeredness, and outlines principles for that tied back into a provision of the Affordable Care Act. So we are trying to work across systems to get to some consistency on this notion of person-centeredness. It's really important. There's a gentleman, and this is not a story that I know the person directly. I know somebody else that was involved in it. But there was an older gentleman who, in his 80s, was living at home and had care providers coming in to support him. And they were running into some challenges because the first thing that needed to happen each morning was he had IV medications that needed to be dispersed, and he was getting a little belligerent about it. Some people might call it non-compliant, right? So he didn't want this process to unfold in the morning, and the care providers are struggling with it, and you know, everybody's trying to figure it out, because this is a guy who's generally not somebody who has a lot of behavioral issues, and then not somebody that had difficulty with medication issues. So you're trying to figure out what this problem was. So he kept talking about the hummingbirds. And and these providers that were coming in on a regular basis couldn't figure out what this gentleman was talking about with the hummingbirds. Till finally it dawned on them, oh, let's talk to one of his daughters about what he's talking about related to the hummingbirds. The conversation at that point had evolved to a place where there was actually discussion in his care team about how are we going to find a residential placement. We can't manage this guy at home. We can't get meds into him. We can't keep him safe. He's becoming a real issue. Daughter, who lives long distance, was brought into the conversation and said, well, is anybody taking care of the hummingbirds? And the staff said, well, what do you mean? And she said, for 60 years, this man's morning activity has been to get up and feed the hummingbirds. He wouldn't eat breakfast. He wouldn't, say hello to us as children in the morning until the hummingbirds were fed. Feed the hummingbirds. And of course, home health staff kind of went, feed the hummingbirds. They figured out a process whereby they could feed the hummingbirds. And lo and behold, he could see that out of his window. They were able to have a conversation about feeding the hummingbirds, and he stopped fighting about getting his meds. That's what person-centeredness is. And we need to bring that in to everything that we're doing, because far too often the battles are not related to what's right in front of us. It's something that we can't see because we're not listening. And I would argue that we do the same thing often when we're talking to families. The question isn't necessarily, do you just need respite, or how will respite help you? It's, what do you need and why, and is respite part of that? And how are we going to figure this out? And looking at it holistically. Families want to be able to do this work, right? We all know, we were able to run through those dire statistics about the economic impact, the physical impact, the health impact. And at the end of the day, we also have all the data that says that families don't want to make a different choice in many circumstances, that families get great satisfaction and emotional and spiritual joy from supporting someone in their home or in the other person's home, or whatever the circumstance may be. And we have to figure this out. I mean, provider-controlled settings, for most of us, at least, should be our last resort, right? I have yet to meet And if somebody in this room wants to stand up and say you're the first person, but in meeting with people and talking to people all across the country, I have yet to find the person who stands up in a room like this and says, living in a nursing facility is on my bucket list. Right? So, I'm looking, just making sure, I want to be able to keep using that talking point. You know, people end up moving out of a place where they are loved and a place that is familiar to them in crisis, and because we haven't planned or thought through things, and because family caregivers have other circumstances or wear themselves out. I mean, we know all the reasons, right? So how do we make sure that family caregivers and older adults and people with disabilities can continue to have that opportunity, and can we continue to move this conversation forward? We also know, in looking at programs across the Administration on Aging, the Administration on Developmental Disabilities, some of the research, some of the things that we talk about and look at at HHS, we're thinking about this, you know, in a big picture. The conversation has to be bigger than Medicaid, right? We've done a fabulous job of leveraging Medicaid for long-term services and supports, and at what cost, right? It makes it harder to have the conversation about the hummingbird. It means that for a family who has a child with autism who is a runner, that instead of having a conversation about how do we make sure there's an appropriate fence at their house, we're gonna glue a staff support to them, which may be more restrictive, and because we can match it, right? It's a service. Fence is not a service. Fence might be a hell of a lot cheaper and ultimately might be less restrictive, but we've, in our decision process at the state level and at the federal level, by moving our conversation so that it is so primarily focused on Medicaid and often not the smaller programs and some of the things that we're doing with state general revenue funds, we've lost that whatever it takes, right? For those of you who were doing family support and respite in the 1980s, you know, that was the mantra, right? Whatever it takes, what are we gonna do to support people to meet their needs? And if that means, you know, that we need to buy a fence, or we need to figure out noise canceling headphones, or whatever it is, that might make more sense than a list of services that are now required to be reimbursable by Medicaid. The other thing that I think we've done, all with the best intentions, is we've created such a fragmented approach to supporting families that families often feel overwhelmed just by the interaction with the system, right? It's like, I don't need another IPPPP da-da-da-da meeting, right? I don't need, you know, I don't need to spend my time figuring out how to fit into your system in order to have my needs met, or not have my needs met on a very minimal basis. And that's certainly something that we hear a lot from families in terms of our formal intersections with the families. We have to begin to think again from a person-centered basis, how are we gonna do this? And listen to the families. So we know a lot about what we don't think works. At ACL, we are engaging in a set of initiatives and activities around how do we get to a place where we have systemic approaches at the state and local level that ensure that we have a coordinated set of strategies, not just services, but strategies that ensure that families who are supporting family members with functional support needs have access to person-centered and family-centered resources, support services, and other assistance. The strategies should be directed to the family, but ultimately benefit the individual with support needs, which is the other challenge with Medicaid, right? Medicaid is designed for the person who's the beneficiary. And we've gotten really creative in some places in figuring out how then we make sure that families are also supported. But we need to take it back into a holistic conversation. We want to move towards systems that maximize the capacity, strengths, and unique abilities of families so that they can best support, nurture, love, and facilitate the preferences of their family member, improve the quality of life for both the family member and the individual at the center through that combination of formal services, natural supports, and integration in the community activities and relationships. So at ACL, we have formal mechanisms. We have the National Caregiver Support Program. We have some family support programs that we funded through the Developmental Disabilities Act. We have Lifespan Respite that focuses more on the infrastructure and fostering collaboration and kind of planting seeds so that the states then can work on how do we actually get to the services. And we are looking at, through a variety of efforts, how do we allow those evidence-based practices that are really making a difference in people's lives to bubble up through a variety of mechanisms. We've learned over the years through all these different programs and again in looking at the research and talking to advocacy organizations and doing some analysis, that we found there are three kind of buckets of primary strategies that are consistent in supporting families. Family needs fall into three categories: knowledge, training, and skill development, right? So do you know what you need to know in order to do your job as a family member? You know, whether that's medical tasks or how to participate in one of those planning meetings. Emotional and social supports, which often can be formal support groups or they can be peer-to-peer. You know, they come in lots and lots of different forms. We don't have robust behavioral support options that are targeted to family caregivers. And then we have instrumental supports, right? The goods and services. What can we buy on the plan? Each of these areas are critical for families' ability to facilitate and manage productive lives for both themselves and individuals they're supporting in their families. We also know that the families need flexibility to be able to adapt those services and supports to their particular circumstances. Consumer direction, right, is something that people are interested. They want to be able to choose who's supporting them, how they're being supported, and manage it themselves. They don't want an agency to come in and say, this is how we do it. We also know that we need to be more thoughtful about ensuring that our supports are culturally appropriate and consistent with individual family needs and preferences. The other thing we're thinking a lot about is how solutions need to be tied to the local community. Back to the Trader Joe's story. Social isolation can only be addressed at the local level, right? It's about relationships. It's about opportunities for people to be supported in ways that go beyond just the formal services and supports. So we're looking and thinking a lot about how communities can leverage existing resources, what local ownership means, and how we encourage reciprocity. We're evaluating existing programs through that lens. We are pushing forward. Actually, Tennessee is one of 6 states that are participating in an initiative on the developmental disabilities side called the Supporting Families Community of Practice, that are looking at family support through the lens of across the life course. And again, what's the balance? What's the mix of natural supports and paid supports, and how do we do this? We have invested in new data collection to understand which services and supports are being utilized in the states by families. We are also looking at some surveys and some instruments and doing some work in research around what's happening for families who are caregivers or providing support but are not currently intersecting with the Medicaid system, right? So a lot of folks who are getting by with just a little bit of help and haven't tipped over into Medicaid. And last, I mentioned that under the Workforce Innovation and Opportunity Act, the Institute, the National Institute on Disability and Independent Living Rehabilitation Research is moving to ACL. Prior to that, we had actually already started a process in working with NIDR in establishing a national resource center on family support issues that was just announced like 2 weeks ago and will be stood up over the course of the next 5 years to really look at both the research needs as well as the training and technical assistance and the establishment of evidence-based and best practices. So those are all small pieces on a relative scale of the challenge that sits before us, but I think are foundational to continuing this conversation forward. What you guys are doing and continuing to beat the drum around respite and supports to families and family caregivers is really important. I don't know if enough families say that to you. I hope they do. It's so important. And there are millions of families across this country who want to be able to stay whole, and we have to continue to figure out ways to make sure that they can. We know that families are seeking this empowerment and capacity. That may not be the words they're looking for, but they want to be able to do right by their family member, and they want to be able to do it in their own way. And we have to find ways to support that on a person-centered basis, as well as providing the immediate relief that services like Respite can offer to folks. As we talk about services, I encourage you to think about the role of person-centered thinking. How do we go back to those individuals? Social capital and reciprocity in relationships, and the involvement of the broader community. I know some of you are doing that. I saw the agenda. There's some awesome things going on in terms of, how do we engage with volunteers? What do we do with college students? What do we think about in terms of all of the community resources? And we have to continue that conversation, and we have to take this on as a country and as a set of local communities, because this is all of us, right? All of us are going to hit a point where we need support. Numbers don't lie, right? 2/3 of us will need some level of support with activities of daily living if we make it to 85, and frankly, I think the alternative stinks, right? So how are we going to do that? I appreciate that you're thinking about these things. I think these solutions are going to come from our local communities. I think that the conversation is overdue. And I, for one, am grateful for the work that all of you are doing to further that conversation and to make sure that adults with disabilities, children with disabilities, and older adults who need support are having their needs met by the families who love them. Thank you.